After his presentation, we will open up the session to questions and answers. So the topic today is using MRD status as an endpoint for drug approval. And I wanted to include this topic because although MRD testing is becoming more widely accepted and performed, experts still disagree on what to do with those results. One of the questions that they have is whether or not to use MRD status as endpoint for drug approval within clinical trials. So here to give us more about this topic and share his opinion is Dr. Mohyuddin. It's my pleasure to introduce him to you. He completed his medical training at the prestigious Aga Khan University in Pakistan. He completed his internal medicine residency at the University of Kansas, where he developed a passion for medical education and treating hematological malignancies. After residency, he pursued chief residency at the University of Kansas, focusing on mechanisms of novel educational delivery and improving access to research for trainees. He completed his fellowship at the University of Kansas, developing a clinical and research interest in multiple myeloma, drug repurposing, quality of scientific methods, end-of-life, cost-effective or evidence-based care, and medical education. He enjoys the outdoors tremendously, and that drew him to life in Utah, where he is currently an assistant professor at the Huntsman Cancer Institute with a focus on multiple myeloma. Dr. Manni, we're so excited to hear from you today. And with that being said, the time is now yours.
Perfect. Thank you for that kind introduction. I'm glad to be here. I'm just gonna share my screen here. Just give me, I'm so sorry. It's this
No, it's okay.
PowerPoint business, right? Do I need to click that swap displays again?
Yeah.
Okay, there we go.
Perfect.
All right, perfect. So the topic of today is MRD, and I know MRD is a complicated topic. It's a complicated topic for me to grasp. It's a complicated topic for other clinicians to grasp, and it definitely is a complicated topic for patients to grasp. So my goal today is going to be to try to sort of demystify and simplify MRD and explain the pitfalls, the promise, and unfortunately, as is with a lot of things that we do, there's a lot of hype with MRD as well, and my goal today will be to try to keep things real, try to stay away from hype and tell you the promise, the potential, and the shortcomings of MRD. I have no conflicts of interest to declare, and I'm not being financially compensated for this talk. So MRD, which could stand for measurable residual disease or minimal residual disease, depending on who you ask, basically allows you to detect really small quantities of malignant cells, right? So if you have multiple myeloma and you're looking at the M protein on your electrophoresis, or if you're looking at kappa and lambda light chains, you generally, you need to have a decent amount of disease in order to detect them. Now, even if your M protein becomes undetectable, or if your light chains are normalized, there's still a decent chance that you have cancer cells there. And that's where the role of MRD comes in, where you can detect malignant cells down to a very sensitive level, right? So some of our assays can detect 1 in 100,000 or 1 in a million cells. So you run 1 million cells through that assay and it will pick up the one cancer cell that's there. So MRD, basically, the simplest way to think about it, allows for detection of smaller amounts of disease. So I'm not the one who came up with this analogy, but it's a very, very useful analogy. I actually don't know who came up with this, so I've given credit to lots of different people there at the bottom left of the screen. But at the time you're diagnosed, you have a lot of cancer cells, and as your light chains come down, as the M protein comes down, we're basically going to, we're chipping away at the areas of the iceberg that aren't readily visible above the surface of the ocean. And MRD sort of comes in where, there's still some of the iceberg left, and, you're getting lower and lower down. And even with our most sensitive MRD assay, there's probably still is some cancer cells that you're not picking up, right? So even if you go down to 10 raised to power minus 6, which means you're picking up 1 in a million cancer cells, it's not a cure. There's still some cancer cells that your assay is not picking up. But conceivably, you're getting rid of more and more cancer cells, and maybe you're getting closer to a cure. Well, we'll talk about that and all of the implications, but that's where MRD comes up, being able to detect smaller and smaller amounts of disease, being able to go deeper and deeper down this iceberg. So MRD, so having established that MRD is just a way of picking up really small quantities of disease, it gets messy real quickly because there are many different ways that you can check it, right? So one is something that we call next generation sequencing. Basically, it means that you're looking at a specific DNA sequence on the cancer cells, you're identifying it, and then you're using that and picking up those sequences that are unique to the cancer. You're using those basically and looking for them with future assays. So let's say at the time of diagnosis, you got a test done, whether it's clonoSEQ or whatever, you get a test done, you pick up this specific genetic sequence in your cancer cells, and now you can use that. So you get induction treatment, and you can now see whether you're able to pick up that specific DNA sequence again. That is called next generation sequencing. Next generation flow basically is that you're sort of running these cells through a gate, and the gate picks up a certain it picks up a certain receptor. So if the myeloma cells have that receptor, every single time a myeloma cell goes through that gate, it's going to record a hit. And that's basically flow cytometry. So you can run 1 million, if you have a next generation flow assay that has a sensitivity of 10 raised to power minus 6. Basically what that means is you run 1 million cells through that gate, and you run one cell that has the markers that myeloma has, and it will pick that up, and you'll be MRD positive. So that's what next generation flow is. So different ways, NGS versus NGF, next generation sequencing versus next generation flow. The sensitivity can vary, right? So you can have the ability to pick one in 10,000 or 1 in 1 million or 1 in 100,000. And then MRD currently is largely done by repeating bone marrow biopsies. So you're doing it on a specimen that's collected from a bone marrow aspirate. So that is an invasive test. And if you want to check MRD frequently, you've got to do bone marrow biopsies frequently. And none of you like getting a bone marrow biopsy done. So that is problematic. There are newer assays that are looking at the peripheral blood, because that's how we check the M protein, right? That's how we check the light chains. It's a reliable, convenient way to check, response assessments. But currently, the technology is used mostly for bone marrow biopsies to check MRD, but hopefully that's changing. And then the other thing is that the quality of the sample can make a huge difference. So you hit a spot that doesn't have a lot of disease, or you get a specimen that's diluted with blood, like you're not getting bone marrow, you're getting peripheral blood, like it can really change your analysis. So it's very operator dependent, technique dependent. So those are some considerations when we talk about MRD, where the specimen was from, what the sensitivity was, and what kind of assay was used. All right, so now I kind of want to get into the nitty-gritty details, and I think it's very important as patients to sort of recognize this as well, because these terms are used very loosely, and unfortunately they mislead a lot of people. So we know that patients who are MRD negative, so let's say you give 100 patients the same treatment, okay, and 50 of them achieve what we call MRD negativity, and 50 of them don't achieve MRD negativity. So 50 of them, you've chipped away really at the iceberg, and you're not even picking up cancer cells with your assay. And like the other 50, you're still picking up some cancer cells. We know that the 50 who got MRD negativity are going to have, are usually going to have longer responses. So they have more progression-free survival, and they tend to have a longer overall survival. So MRD negativity is undoubtedly prognostic. If you got VRD, right, for induction treatment, and you achieved MRD negativity with VRD alone, then we know that you're likely to have a prolonged PFS compared to somebody who didn't achieve VRD, or didn't achieve MRD negativity. So all of these, when this meta-analysis, there's graphs that I've sort of highlighted here. So that's a lot of patients, right? That's like 8,000 patients. But what has been done here is that you've looked at a whole bunch of different trials, and you've pooled all of the people who achieved MRD negativity, and you're comparing those to all of the people who didn't achieve MRD negativity. All right. And this is a very important point to remember. You're pooling people across both arms, whether they were in the control arm or the intervention arm. You pool all of the people who achieved MRD negativity, and you compare them against all the people who didn't achieve MRD negativity. And you highlight through this pooling and comparison that MRD is undoubtedly prognostic. Achieving MRD negativity means that you're going to have a better PFS. So does this settle the story? Those who achieve MRD generally do better than those who don't achieve MRD. Is the story settled? Does this make it an appropriate endpoint? Is this the best surrogate endpoint for overall survival? Should this be the goal of our treatment? It's a little complicated. So, based on this study that I showed you, lots of tall conclusions were drawn, right? That MRD is a surrogate. MRD should now be the goal of our treatment. The problem with this analysis is you're basically comparing people who have disease biology that is responsive to treatment to people who have disease biology that is not that responsive to treatment. So as you all know, myeloma is a very heterogeneous disease, and your disease course is very different than another person's, right? You could give the same treatment and you could get really different outcomes. When you do an analysis like this, you basically are highlighting disease biology as much as you're highlighting the effectiveness of treatment. So, when you compare people who respond to people who don't respond, you're basically comparing people with biology that's responsive to biology that's not responsive. It's not necessarily by itself a measure of the drug's efficacy, because in this analysis, you've pooled people across different arms, different trials, different populations. You've just pooled those who responded and compared them to those who didn't respond. So this was a letter to the editor where, and I love this. This is probably the most eloquent thing that anybody has, in my opinion, anybody has ever written about MRD. Because based on this previous study, the authors were like, MRD should now be a surrogate, right? So these folks basically like so eloquently described that to establish, and I've highlighted here, and I'm going to sort of try to simplify this for you. But let's first read this. To establish MRD as a trial surrogate, one needs a meta-analysis to show that between arm differences in MRD status accurately capture or predict between arm differences in survival. In contrast, pooling RCTs, which is randomized controlled trials, experimental and control arms, and then comparing survival between MRD positive and MRD negative patients does not take advantage of the RCT design and is focused on comparing outcomes between patients with a good prognosis and those with a poor prognosis. So this analysis does not establish surrogacy. For surrogacy, you want to look for each arm, how much the difference in MRD negativity rates correlates with the difference in something that actually really matters, like overall survival, right? So basically, when we summarize all the literature, you look at all the papers out there, we know that those who achieve MRD negativity have a better PFS than those who don't. But what we don't know is that additional interventions to make more people achieve MRD negativity, does that make people live longer? All right. So we know that if you got VRD and you got MRD negativity, you are expected to have a longer remission than if you didn't get MRD negativity. All right. But what we don't know, and I say this with full humility because I don't know, and maybe time will tell, but what we don't know is doing additional treatments to try to increase the amount of MRD negativity. Does that actually translate to more people living longer? We don't know that. And if other people tell you that they're confident about it, I don't know where they're getting that from, because we don't know that. And I think I am grounded in my interpretation of this, but other people might be more confident in their interpretations. And the reason why I'm grounded is that history would suggest a bit of caution in deciphering too many conclusions from this. So this is a trial that you may or may not have heard about, but it's one of the most consequential trials for myeloma, called IFM 2009. So if you have underwent an autologous transplant at any point in your disease course, it's likely that your clinician, your myeloma doctor, was using the results of this trial. So in this trial, half the people, so it was for newly diagnosed myeloma, half the people got VRD and then proceeded to a transplant. The other half just got VRD, then got some more cycles of VRD and didn't get a transplant upfront. Okay, so VRD plus transplant versus VRD. Those who didn't get transplant upfront, more than 3/4 of them got a transplant later. Okay, so VRD plus transplant versus VRD, but no upfront transplant. Now, as you can see, the PFS for VRD plus transplant at 47 months is a lot more than the PFS for those who got just VRD. It's more than a year difference. And if you look at the MRD negativity rates, it's a lot more for those who got transplant, 80% versus 65%. All right. But what is the number of people who are alive 8 years out is the same. Okay. So more people were MRD negative upfront with the auto transplant, but that did not translate into more survival because people just got that intervention later. All right. So there's so many caveats. And like when I see people draw these tall claims that, more MRD negativity means more survival, I look back at history and I'm like, I don't know if that's true if you got those responses later, if you got those regimens later. And I agree that a lot has changed since then. All right. That trial, it's called IFM 2009 because it was conceived in 2009 and started in 2010. A lot has changed since then. The MRD of 2009 or 2010 is very different than the MRD of today, right? Our therapies are better now. We're doing quads, whereas we were doing 3 drugs. We have more drugs available at relapse. But all I ask for is a bit of humility, and I ask for just some introspection and not drawing too tall conclusions. Just more MRD negativity does not automatically mean more survival. And the other problematic thing about MRD is, so MRD will detect, any small amount of cancer cells that are there, right? But we all know that myeloma is a very heterogeneous disease, and there's a lot of different clones that are out there, and not all clones have to be eradicated. There's research that is now, several years old, where there and there are many people. There's some in the audience who they may never have achieved complete remission. They may have, never achieved MRD negativity, but they've stayed with stable disease for years and years and years and years. And if we adopt this goal of making everybody MRD negative, we could be over-treating a lot of people who don't need to be treated. So it could be that you got myeloma, you got treatment, and the clone that's left behind is a harmless clone that behaves more like MGUS and is not going to hurt you. But in our quest to make you MRD negative, we could hurt you. And we're making progress. We're getting better at recognizing what clones are, okay to leave behind. But until this technology matures, if MRD negativity becomes a sole goal of our treatment, we could hurt people, because we have some people who just, they don't become MRD negative, but they stay in that stable status for a long time. The other thing about MRD, and in the relapsed refractory setting, so if you look at the recent CAR T trial, right, where we've got Abecma approved. So there were people who achieved MRD negativity, like they're heavily relapsed people, like, right? These patients have had so many treatments and they've relapsed so many times, and you gave them Abecma and you even achieved MRD negativity, okay? But it was fleeting, and the progression-free survival, you still only had a progression-free survival of 8 months, right? So when we talk about this, MRD as an endpoint, you're getting results quicker. In some situations, especially for heavily relapsed disease, like you can get your answer from progression-free survival fairly quickly as well. And even though you achieve MRD negativity, it could be fleeting, right? So in some situations, PFS, OS is still practical. But now if you look at newly diagnosed disease, right, where you're getting like 5, 6, 7 years remissions with just your first line of treatment, waiting for overall survival will take time. So I recognize that, for especially at least for newly diagnosed disease, like it could take a long time to wait for PFS or OS. And I recognize that there's a need for endpoints that, give you an earlier result, but you have to be responsible with them. You can't just loosely just claim that, this is a surrogate for overall survival. Like you might just have an informed discussion with your patient and be honest about it. That's all I ask for. But I think that in many situations, especially for all these new drugs coming to market, where if your MRD negativity is fleeting and you're getting an answer within a year, then I would go with something more reliable, something more robust, something less prone to those errors that I mentioned earlier. And the other thing, so MRD basically is, it's like you're detecting really deep responses. But the reality, if you look back, and I contemplate a lot about the history of myeloma, is there have been many historical examples where a drug has actually caused more responses, but killed more people as well. All right. Now, we used to use high-dose dexamethasone a long time back. And then it was actually a patient that came to Dr. Rajkumar with this idea. And they compared high-dose dex versus low-dose dex. High-dose dex had a higher response rate. All right. But as you can see on the survival curve here on the right, that high-dose dex killed more people. So response rate does not always mean survival. And I think the same caution applies to MRD. If we had MRD technology at that time, or even today, I mean, I'm pretty sure if you design a trial today, you give high dose dex in combination with other therapies, you'll probably get more MRD negativity. Is that the right thing to do? No. And then we've had recent examples. I'm not going to delve too much into them, but you've had melflufen, you've had venetoclax, where these drugs caused more responses, but they also led to more deaths. So response rate is a meaningful in the sense that, yes, we figure out whether our treatment's working or not, but it does not always translate to living longer. And I would urge the same caution for MRD. What do I like about MRD? So I'm going to give you some examples where MRD can allow for customization of treatment. So right now, our current landscape for myeloma is you get started on treatment, regardless of how well you're responding, you could get an exceptionally deep response, or you could get a minor response, a partial response, you're going to get the same treatment. So MRD can, if in a well-designed trial, can allow us to customize treatment based on response. If you're responding really, really well, maybe you don't need treatment for that long. Maybe you don't need treatment that is that intense. Maybe you don't need to stay on treatment forever. That is exciting, and I love that about MRD. And it could conceivably shorten time to approval in the newly diagnosed, and maybe even in the early relapse setting. But there's huge caveats for that. If that becomes the sole goal of treatment, MRD is a little problematic. What do I not like about MRD? So the term surrogacy gets used very loosely in the literature. I mean, today I read a post from Onc Live where they were like, this is, expert describes upcoming surrogacy of MRD in myeloma. And like that sends a chill down my spine, because there's only so many things that I can go out there and address, but it's not a surrogate, right? It's not a trial level robust surrogate. And MRD as an endpoint is agnostic of toxicity, death, and quality of life. I don't like to speak on behalf of my patients, but when I talk to my patients and I ask them what really truly matters to them is living longer and living better. And that doesn't necessarily mean MRD, right? You could have, if you make MRD the sole endpoint and you compare two interventions, one intervention could kill more people and still have a higher MRD negativity and still be deemed as the successful intervention arm, right? So it's problematic. Bone marrow biopsies are needed, and that will hopefully change, but that's also invasive. And we do not know that escalating treatment to achieve additional MRD negativity will make people live better or longer. But we do know that if you give more treatment, side effects are more and decreased quality of life are likely. And then again, there's some people, as I mentioned, who have clones and they can stay MRD positive for years and years without progression. Why treat? So MRD doesn't always account for clones that aren't destined to cause problems. So lots of things to be excited about, but lots of things to be wary about as well. So this was published in the most prestigious journal, hematology journal, in Blood. All right. So you have experts, this is the most prestigious journal, but you see how loosely the term MRD is used, right? So the same meta-analyses, or, it does not mean that, MRD becomes a surrogate. When you compare people who respond to people who don't respond, you cannot make claims on the efficacy of a treatment based on such an analysis. So, it's problematic, right? Like, I recognize, like, I have patients that, I've lost several patients over the last few months, and it really hurts me, and I want better treatment options, but I also recognize the need to be responsible. But the reality is, does it matter what I think? I don't think that at this point in time, MRD negativity should be the sole goal of treatment or the sole endpoint of your trial. But I don't think it really matters what I think, because we already have a randomized trial that was presented at ASH 2021, where isatuximab VRD was compared to VRD, all right? And lo and behold, you had more MRD negativity with ISA-VRD. Now, we know from some other trials that a single time point of MRD negativity can be fleeting. So it may very well be that if you follow up 6 months later, the MRD negativity rates of ISA-VRD might change. You might have less or more or whatever, or you might have, more or less with VRD. Like, it's a single time point of MRD negativity can be fleeting. We know that based on analysis of other trials. So yes, based on this trial, yes, ISA-VRD gives more MRD negativity. Does ISA-VRD make people live longer? I don't know. It will take a long time for us to figure out. What do I do in the interim? And the reality is that we don't know. And many experts will give you many different answers. But that's sort of one of the issues here, that if MRD negativity, and especially a single time point of MRD negativity, becomes your sole goal, then it gets a little confusing. And the fascinating thing is, despite this trial, they polled doctors recently, and like, most people would still use either VRD or DARA VRD. Like, it hasn't really changed much. Sanofi is now telling us that, we're the first company to show increased MRD negativity based compared to VRD alone in a randomized trial. But what does that mean? Like, can I counsel my patient that you're going to live longer or better because of this? And I don't know. And I do use quads. Don't get me wrong, I do use quads, but I have a long discussion with my patients that, I don't really know, but I hope that this deeper response that I'm trying to achieve will translate to prolonged survival. So what do I love about MRD? So, Dr. Costa presented this amazing trial it was presented several times, but it was at ASH 2021, where they used MRD to take people off treatment. So you give everybody intense treatment with quads, you do a transplant, and after a transplant, if people are MRD negative, you take them off treatment. Now, this approach is exciting, right? Maybe this is what the future is. And there are trials that are now looking at whether we can avoid doing a transplant for people who are MRD negative before we're heading into transplant. Like, that is exciting. The ability to customize treatment, the ability to take people off treatment is exciting. It becomes tricky when it becomes the sole endpoint or the sole goal of treatment. That makes me uncomfortable, but this is exciting stuff. There's another example of MRD used well, the dramatic trial, where after a transplant, you get maintenance. You could get one of either two arms, but if after 2 years you're MRD negative, you have a chance to be randomized to be put off treatment. Now that is exciting, right? That's the reason why I enroll people on this trial. I tell them there's a chance that if you're MRD negative, I can get you off of treatment. Like, that is what our patients look forward to. So my final thoughts, it is a very good prognostic tool. I'm not saying don't check it, because like, it gives you insight on the patient's disease biology and how responsive they are to treatment and what to expect, right? And in a well-designed trial, it can allow us to customize treatment based on response. It is not a surrogate. No matter how many times you read the surrogate term thrown loosely, like the goal of today is it is not a surrogate until proven. It hopefully will become a surrogate someday, but we can't establish surrogacy based on the type of analysis we're doing nowadays. There are analyses ongoing, but it'll take time. To make the sole endpoint of a trial or make this the sole goal of treatment can be problematic. The reality of it is that industry wants their products used early and wants their products used for as long as possible. If you make MRD negativity the endpoint of a trial, it's a lot easier for your drug to win, right? VRD plus whatever, data VRD plus whatever. If MRD is the goal of treatment, your product wins early, even if it causes more toxicity. I mean, it could conceivably have, a few more deaths here and there, but it becomes a lot easier for industry to get what they want. And a lot of the times what industry wants is the same thing as what you or I want, but not always, right? What we want is better treatment options. What they want is more treatment options and more of their treatment options. And sometimes that aligns, but sometimes it doesn't. And I think it's important for us in academia to be honest and upfront about what we're selling and what we're doing. And maybe it'll be a compromise because I recognize that it's taking longer and longer. So to optimize our newly diagnosed treatment regimens, maybe resorting to newer endpoints is the way to go, but it is important to call it what it is and be cognizant of those limitations. So I deliberately planned for about half an hour so that we would have another half an hour to sort of talk about some questions that you all might have. And it's a complex topic, but hopefully I did some justice to it and made it a little simpler for you all.
Thank you so much, Dr. Manni. I, first of all, just want to say thank you for your authenticity, for your honesty, because I think that's much needed in this field. As you were saying, really the patients do want to hear that there's a cure, but they'd rather hear the truth so that we can have honest research get us to a cure, if that makes sense. So I appreciate your honesty there. We have several questions coming in, and I'd just like to remind our patients, if you want to enter in your questions, there's a Q&A button at the bottom of the screen, and that's how you can answer some of your questions. So one of the questions that I want to address first and foremost, people are wondering if MRD is not the end goal, then what is? And if you could explain one more time PFS and OS and what that is.
Yeah, so the end goal for me, when I talk to my patients, and I don't want to assume on behalf of my patients, is to live as long as possible with the best quality of life. And you can measure that. So you can measure overall survival. Overall survival is the time from when you start your intervention to death, basically. So how long you live. So that, or quality of life, and we have instruments that we can use to measure quality of life, and those are the true things that really, really matter, right? Progression-free survival is the time from when you start the treatment to either when your disease progresses or if death happens, whichever of the one comes first. So progression-free survival, even progression-free survival doesn't always translate to overall survival, but progression-free survival is a widely accepted measure because you have so many different treatment options in myeloma, right? And you can cycle through one after another. So overall survival is a complex endpoint to ascertain because of overall survival is dictated not only by the treatment you're getting right now, your first treatment, but also by what treatments you get after that, right? So it's a complex endpoint to measure. But and it's almost a philosophical question that you ask, that if MRD is not the goal of treatment, then what is? The goal of treatment is to make you live as long as possible with the best quality of life as possible. And that takes time, right? And to find out the right way to do that with trials, it takes time. So that is the answer to that question. Can I just take another question straight off of here?
Of course.
So there's hold on just one second. Sorry, so I apologize. So VRD, and I assume that my apologies, I should have been more clear, but that's Velcade, Revlimid, and dexamethasone. So it is historically been the most commonly used treatment for newly diagnosed myeloma, VRD, right? VRD. So I've been using that term. I'm sorry, I should have been a bit more clear about what it meant. So that's VRD, just standard induction treatment, the 3-drug regimen that a lot of you probably got when you were diagnosed. What would I consider a heavily relapsed patient? So generally, if you relapsed once, that's called early relapse. And generally, if you relapse like 3 or more times, it's a 4th relapse, 5th relapse, that's a heavily relapsed disease. So first relapse, I would say, is early relapse, and second relapse, I guess, can be defined variably, but more than that is heavily relapsed disease. Now, we've been trying to standardize our MRD assays, and there was a very good paper that was published earlier, I think it was published last year, because MRD has been measured in so many heterogeneous ways, as I mentioned earlier, that it needs to be standardized. So we are in the process now of standardizing how we measure MRD and how we report on MRD, but it historically has been a little messy. So we are in the process of trying to standardize that. And I think one of the questions is there, some of the trials use MRD status with 10 raised to power minus 5, and some use 10 raised to power minus 6. Why is the criteria not always using 10 raised to power minus 6 or NGS? And the truth is that it boils down to the availability of the technology, who is funding the technology, and when that trial started. So those older trials you have some of them are even 10 raised to power minus 4. Some of them are 10 raised to power minus 5, but those newer ones you have are 10 raised to power minus 6. So it all depends on the availability of the technology and the funding. And I mentioned this earlier, but if your MRD assay is 10 raised to power minus 6, it means you can detect one cancer or one myeloma cell amongst 1 million cells. So I think I had a slide here about that. So I know that somebody had a question here. And they're all really, really good questions here. I'm trying to see here.
Yeah, one of the questions that kind of relates to what you were just talking about, they said, I am MRD positive. Did the MRD I took show how many cancer cells exactly there are among X total number of cells?
Yeah, so you should ask your doctor about what assay was used, and the assay should report the sensitivity, which is basically 1 per 10,000 or 100,000. But
are they able to see? I've actually had a question about this as well, because I think different people have said different things. Are you able to see there was 10 cancer cells within 1 million, or was there 15? I don't think you can, right? It's just positive or negative.
Yes. So for all practical purposes, like the result of MRD that really matters is positive or negative, right? You will quantify the disease through other methods, right? But MRD, once you know what assay you're using, it's like, do you have MRD negativity or do you not have MRD negativity? It's more of a yes/no phenomena for all practical purposes in the sense of how we use it. But depending on the assay, so like, again, I don't want to get too complicated here, but like if you're doing like a next generation flow, it can tell you. So let's say you have a bone marrow biopsy, you had 70% plasma cells at the time of diagnosis, and you got whatever treatment you got, and now you have 10% plasma cells left. Your MRD assay can actually tell you what percent of those 10% cells left are cancerous and what percent aren't. Okay. So that is interesting information, but for practical purposes on how we like describe it, it's either MRD positive or MRD negative. But yes, you can get some ascertainment of like what amount of cells are left behind. I know that Cindy had a very good question here. What kind of a test can tell if a remaining clone after treatment is an aggressive clone and more treatment is needed to get to MRD negativity quickly, or if that clone is an MGUS-like clone and you can have stable disease for years without ever getting to complete remission? Is this test easily available? And that is a great, great question. And the short answer is that it is not easily available. These tests have been developed by the University of Arkansas, and they've been existing for a long time. But that testing is one way that you can sort of use to sort of decipher what clone is left. There's some really good testing being done from really good papers that are coming out from Europe, where we're also sort of looking at this technology and deciphering what each clone means. But for practical use in the clinic today, we do not really have access to that information, unfortunately. So, there's another really good question. I'm so sorry. I should let you do this.
It's okay. If you
Right
feel
up there.
comfortable, go ahead. Go ahead.
Does MRD testing make sense at all for certain patients, such as frail patients who have never had a transplant? Would it help to optimize treatment? And I think that is a fantastic question. And I hope that that is what the next wave of clinical trials is going to answer. So I gave you the scenario of somebody who has responded really, really well. Even before transplant, they become MRD negative. Like, we have trials now that are looking at whether we can omit a transplant for those patients. For this specific scenario, you have somebody who's frail. We don't have trials to guide us, but MRD can be something that we could use. It's one more tool in the box. It by no means is like the perfect tool to answer this question. I think that, for, let's say you have an elderly patient who's very frail, has a lot of comorbidities, like a lot of the times your goal is to try to control the disease. And you're not really looking to necessarily even get them in a very, very deep response, because you don't want to cause a lot of toxicity. So you will do some sort of a low intensity treatment. And I would argue to you that MRD is not needed, right? Like, you can just make sure you get the light chains down, the monoclonal protein down, and you keep it there at a stable level for a while, and you just get them to feel better. So I would argue to you that MRD is, you could get by without doing MRD assays for that.
Interesting.
How often to do MRD? So you have to do bone marrow biopsies, right? And nobody has a clear-cut answer for this, because different people will tell you different things, right? Like, if you're in a really, let's say you've had a transplant done and 5-6 years have passed and your disease has not come back, and for whatever reason you decide to get MRD checked and you're MRD positive, what are you going to do with that information? Nobody really knows the right way to deal with that scenario. Or let's say that you have been getting MRD checked frequently every year after a transplant. For the first 5 years, you're MRD negative. The 6th year, you become MRD positive. Now, what do? We know,
do you start treatment or not? Yeah.
We know based on data from Arkansas that MRD negativity can precede biochemical relapse. So what that means is you're no longer MRD negative. You used to be, but you're not. And your light chains are still undetected. Your light chains are still normal. You still don't have an M protein. This, existence could stay for several years. You could have several more years without treatment in which you were MRD negative previously. Now you're MRD positive, but biochemically, you're still normal. And I would tell you that you're probably not going to get organ problems with this. So the scary thing with myeloma is getting kidney dysfunction or getting a new fracture, getting worsening pain. What I would argue to you is that if you just became MRD positive, you're not suddenly going to develop a bone fracture, or you have time. It has been shown that it takes time for you to have biochemical relapse. And then by then you probably should, get your treatment adjusted, but, and then to develop clinical relapse, myeloma coming back with a new extramedullary disease. Now, not everybody's disease follows these rules, but generally it takes time and nobody really knows. And that's another thing about MRD, where it's a slippery slope, where if you start treating people early, if you start treating people at MRD negativity, and you design a trial with the goal of getting people, back to MRD negative, what are you achieving? Can you tell me with confidence that this is going to make my patient live longer or live better? I don't know, right? These things take time, but I think that, we have agents in myeloma, but we have to be responsible with this technology. And we want to make sure that we make our patients live as long as possible, as well as possible, but, do so in a responsible fashion. Because if MRD becomes the sole goal of treatment, if somebody becomes MRD positive and you start aggressive treatment to try to make them MRD negative, it is very conceivable that you will cause toxicity. and you will overtreat patients who may not need treatment for several years.
Interesting. Wow, that's so fascinating.
Yeah.
There's a comment that goes along with that. Would you do MRD testing more frequently with high risk versus standard risk patients? It's interesting because well, sorry, I was just going to go into, it could come back. You could have had, if I'm wrong, please correct me, but it's interesting that the cytogenetics don't necessarily stay the same in a relapse, right?
Yeah. So, I mean, when you ask this question, we have no solid data to guide us for the answer, right? So my answer would be based on my opinion, and somebody else's answer would be based on their opinion, right? The problem with high-risk myeloma is keeping them in remission. Like, you usually get a response with the treatment you give, but then the problem is that the response doesn't stick for a long period of time. So, I mean, I don't know. I don't know whether just having high-risk myeloma would make me want to do more frequent bone marrow biopsies to get MRD negativity. If I had a widely available, cheap assay that my patient was not being charged for, and it was drawn through the peripheral blood, sure, why not? But now I got to be a bit responsible. I don't want my patient bearing the cost of this, and I don't want to do more bone marrow biopsies than I need to. Right. So I just have to be responsible with this technology. But the problem with high risk is that they don't stay in remission for long. And the current assays that we have tell us that, right? So if the light chains are going down and the light chains stop going down, you'll know that within a few months. I don't need to do a bone marrow biopsy to tell me that necessarily. Like, I don't need to repeat that. I think MRD, so, I think MRD for newly diagnosed disease, after giving them a certain amount of treatment, like it gives immense prognostic information. Like, as I mentioned, if you got the same treatment as several other people, but you achieved MRD negativity with that treatment and others didn't, like, I know that you will likely statistically have a much longer progression-free survival, probably live longer than the others, right? So it makes sense to do it early in the disease course because it can give you prognostic information. But once you've relapsed a few times, if you do an MRD assay, like, you will just find out that you're about to relapse a little quicker, but not a whole lot. So I think that, like, widespread MRD testing in the relapse refractory setting is going to be a little hard to justify, in my opinion. I think it's probably still going to be done. Like, all these, I showed you the results of that trial, right, for Abecma ide-cel, where everybody, like, the median progression-free survival was 8 months. So that tells you that of people who were enrolled, like, half of them had either progressed or died in 8 months. Okay. So 30% of them achieved MRD negativity, but, like, it was fleeting. And, like, so what if, like, your MRD negativity was, a certain proportion at 3 or 4 months? Like, you can just get your light chain assessment every month, and you can figure out, when the numbers are beginning to go up. If you are getting MRD free testing that frequently, like, what are you going to do with that information? What if you know that at 1 month it's, you were MRD negative positive? If earlier you were MRD negative and then, a month later you're not, like, what do you do with that information? Are you going to change treatment? Probably not. You're going to wait for the light chains to go up before you decide to do another treatment. So it is a complex question with a complex answer, and we don't really know the best way how to manage that situation. We have trials. I quoted to you some trials that are looking at doing less treatment for MRD negative. We also have trials that are looking at doing more treatment for MRD positive. But until those trials result, today, if you make decisions based on MRD, you do so based on your opinion or based on weak data that we don't really know, like, definitively what to do with that data.
I think this conversation helps too, because I've heard a lot of from concerned patients who don't achieve that MRD negativity and they feel like in some way they failed just because of the connotations that come with, oh, I achieved MRD negativity, now I don't have to worry anymore. And so I think this conversation really helps because there's so much that while MRD is amazing and has its place and its usefulness within the myeloma world, I don't think it should be used as a measurement of whether or not a part of your myeloma identity, I guess, is what I'm trying to say. So I do appreciate this conversation.
Yeah. And I think there's so many caveats. I think it's very important for us to be responsible with how we frame things.
Mhm.
I've had patients that have been MRD positive after transplant, and they've stayed MRD positive for years and years and years and years and years. So
Mhm.
it's,
Mhm.
so I mean, we just have to be responsible. And even achieving MRD negativity does not mean cure. MRD negativity can be fleeting. Like I told you about this, a BECMA trial where you had 30% of people that achieved MRD negativity, everybody still relapsed. And even in the newly diagnosed setting, like MRD negativity can sometimes be fleeting. So it is not
Interesting.
the end point. It's not the, like, it does not mean cure. It can be fleeting. It can come off of a bad specimen. So you could get a bad area of the bone marrow biopsy and come back as MRD negative, whereas in reality you had disease. Or as Cindy has asked a very good question, if you have measurable disease in your blood, is there
Mhm.
another use for MRD testing? So, I mean, there are conceivable scenarios where you have a lot of extramedullary disease. So your myeloma predominantly resides like outside the bone marrow. You have like this accumulation of myeloma cells, like a plasmacytoma somewhere else. It could be that you're repeatedly checking the bone marrow and you're MRD negative on the bone marrow, but you actually have a lot of disease. So MRD negativity, is you got to like use it in conjunction with other things, right? So you want to use like a PET scan or some other form of advanced imaging and make sure that plasmacytomas are being treated, or those
Mhm.
other lesions are no longer really PET avid. You know, it doesn't really mean a whole lot like if your bone marrow is MRD negative and you still have circulating disease elsewhere, right?
Yeah.
And there's so many caveats, right? Because sometimes like you can be MRD negative, but you can still have a M protein that's being detected because the M protein that was made by the myeloma cells that are now dead are still lingering around for a few months.
Oh my goodness.
There's so many caveats to that I think like simplistic statements on MRD like can be harmful.
Yeah, yeah.
Yeah, that's my goal for today, just to sort of tell you how complicated all of this is and how, it isn't a surrogate, and it's a good thing. If you have achieved MRD negativity and you've stayed MRD negative, it's a good
Yeah,
thing.
congratulations. Yeah.
Exactly. The other irony to all of this is, so MRD is being lauded as, it shortens time to approval. So we want something that's quick, right? But now we're realizing and we're using new terms such as sustained MRD negativity, which means
Mm.
MRD negativity lasting 6 months or a year. Well, if it's MRD negativity that's sustained for like 2 or 3 years or whatever, like, I mean, you might as well use PFS, right? Like the point of MRD, there's a bit of sarcasm in here as well, but the point of MRD was like a one-time test, tells you everything. And now we're recognizing that you got to just see if people sustain it. Sustain
Interesting.
MRD negativity over a long period of time is essentially becoming PFS.
Yeah, yeah.
So
Interesting.
it's just a more expensive way to look at PFS if
Yeah,
you sustain it
exactly.
for too long. And again, I don't want to like throw shade upon like this term, because there are a lot of really smart people, smarter than me, working really hard on this. But there is a bit of irony to how like you sell it as this one-time endpoint that will tell you everything, but at the same time, you're building upon this sustained MRD negativity thing because you're realizing that one time is just too imperfect. So yeah,
Interesting.
lots of things to
Interesting.
consider.
Let's change gears really quickly. What if the MRD results detect clonal DNA? What does this mean? The clonal DNA part of MRD results.
Yeah, so it means that you use next generation sequencing, because next generation sequencing is where you look at DNA sequences. And I assume, and again, I'm not talking for any specific patient here, I'd have to look at the report, but I'm assuming that if it has detected clonal DNA, it means that you're MRD positive. Generally, it means that there is still some clonal cancer cells that are detected in small quantities.
Yeah, so there would be definite follow-up needed with your doctor. There's so many good questions here. Let's talk a little bit about mass spec, since it has a little bit to do with, I mean, it's one of the ways that they're testing. Where does it fit in within this conversation, the mass spec test?
That's a great question. So the good thing is, so a mass spec is basically a much more sensitive way where you can like detect like smaller amounts of the M protein, and it is also very prognostic, and it can be detected from the peripheral blood. So it has a lot of the other shortcomings, right? Like, I mean, it has the practical advantage where you're not needing to do a bone marrow biopsy. It has a practical advantage of you being able to detect smaller amounts of disease, similar to MRD. But I think the same caveats apply with, and it also has a practical advantage where you can't mess up because of where you collected, right? Because if a bone marrow, you hit a wrong spot or you get a wrong specimen, you can draw really wrong conclusions. That doesn't apply with a specimen drawn from the peripheral blood. So it has these advantages, but it has the same shortcomings. Like if you make that the sole goal of your treatment, then you're kind of going to run into some of the same issues that I mentioned earlier. So it is also a prognostic test, similar to a lot of the other things that we discussed today, but it is also not a surrogate. But it is exciting technology. It does also, however, lead to some more issues which are not related to today's discussion, where you're going to pick up a lot more MGUS now. And then a lot of, MGUS causes anxiety for people. So there are lots of people who would have lived out their entire existence without ever knowing that they have MGUS because they have such a small protein that's never going to cause them issues. And now you're going to pick them up because you have highly sensitive tests. So there are a lot of like philosophical issues that we could talk about with this as well. But yes, it is exciting technology, and I really like the peripheral blood aspect of that.
Yeah, and that's one of the questions as well. How close are we to not being able to do bone marrow biopsies and just do MRD testing in peripheral blood?
Yeah.
I'll just say not very close.
Sorry, go ahead. Yeah.
No, it's okay. I was just going to say it definitely is solicited by patients, and people are aware of that and doing clinical trials, I believe. But you can speak better to that than I can.
I mean, I think that there are lots of really smart people, smarter than me, who are working on this technology. And mass spectrometry, I mean, there are other ways as well, right? So there's circulating tumor DNA. So small DNA fragments from the myeloma that are just like circulating around in the bloodstream, that can be detected as well. Again, these tests are not readily, widely available, but they could be in a few years. And maybe that's the future of MRD assessment in myeloma, like detecting very small amounts of DNA circulating in the bloodstream, cancer DNA. So it is exciting technology. And I think as the technology, as we know what to do with the data, and as we use the data to adapt our treatment, to modify treatment, it's going to be, widely used. Like I am very excited about the opportunity to, like not give treatment, like stop treatment, or like give less treatment or give less aggressive treatment for people who are achieving MRD negativity really quickly. Like I want trials to help answer those questions for me. If I can spare somebody the toxicity of an autologous transplant, the toxicity of high dose melphalan, this is amazing technology. If I can do that without like, shortening their lifespan, like it's amazing technology. Like I can't understate that. But if it becomes the sole goal of my treatment and the sole one thing I look at, that is problematic. So it is very hard to have a nuanced discussion about MRD, even if you're given an hour. Like it's hard to be nuanced about these things. And I've attracted a lot of criticism on Twitter because I sometimes will say, like I'll point out these deficiencies of MRD. It doesn't mean that I'm anti-MRD. I mean, I love some aspects of MRD, but there's good and bad to it.
I think taking everything with a grain of salt, realizing that everything is going to have its advantages and disadvantages. And there's lots of questions in here about maintenance therapy. I'm actually going to include, Dr. Manni gave a separate discussion to us about the role of maintenance therapy. I'm going to include that recording in the follow-up email that we send along with the resources and the recording, excuse me, as one of the resources, so that you will be able to have the chance to watch that as well, because that was an excellent presentation and he goes into more depth about what is the role of maintenance therapy and when is it needed and for whom. So just so you know that will be in the resources. There's a lot of other questions, but it is unfortunately time to end. I think that was a really good summary that you ended with there, Dr. Manni. And I'm really grateful for your time and your shared knowledge today. Thank you so much for taking the time to share with us.
The least I can do. Thank you for having me here.
Yeah, I'm going to end with a couple of outro announcements and then we'll be done. You can join us next month. Not next month, in April, as we talk about one of the other major questions in this emerging MRD field, How often should MRD testing be administered? And many patients in remission are wondering how often they should be MRD tested just in case. So kind of continuing some of the question and answer discussion that we had today. We're going to hear what medical professionals have to say on this topic in April. And because you're subscribed to the MRD chapter and you were registered in this event today, you will be notified when that event is ready to register for. You may be interested in other myeloma crowd community events we have coming up. Tomorrow on the 25th, we're celebrating Black History Month with the African American Myeloma Community Chapter. We're going to be hearing from Dr. Brandon Blue, who is a Black myeloma specialist, and he will be discussing how to overcome healthcare disparities in the Black myeloma community. On the 1st, we hear from Diana Valentine in the Myeloma Financial Chapter. We're going to be talking about the true cost of blood cancer and how to pay for it, especially what newly diagnosed patients need to know. Then on the 3rd, we're going to hear from Dr. Bodros, who's a multiple myeloma specialist, and he will talk to us a little bit about how to determine whether or not a stem cell transplant is successful. So we'll be able to continue this conversation a little bit of, sorry, something's popping up over here, of whether or not to determine your treatment as successful, because sometimes we get caught up in the little things like, oh, I didn't achieve MRD negativity through my stem cell transplant. So let's continue that discussion a little bit more on March 3rd with Dr. Bodros. The link to sign up for any of those events and even more events that I have not mentioned today is found at the bottom of the slide. It will be sent out as well in the follow-up email after the event's conclusion. As always, I'd like to thank our sponsors one more time: Bristol Myers Squibb, Amgen Oncology, Genentech Adaptive Biotechnologies, Sanofi, Janssen Oncology, Karyopharm Therapeutics, Takeda Oncology, and AbbVie. Thank you so much for helping us build a strong myeloma crowd community. Hope that you have a great rest of your day. Take care.